radiotherapy for brain metastases. There we are. Sorry, there are my conflicts of interest. So I'm employed by the NHS. I've got an honorary position at Imperial. I hold some grants, and I've had some previous jobs as well. So that's roughly what I'm going to talk about. I'm going to talk a bit about background, a bit about what we know. I'm going to talk a bit about what we do, and then some cases, and then finish by talking about what we might do in the future. So, all right, as I think most of you know, brain metastases are common and have a poor prognosis. And the other thing I want to say is that the focus of this talk is on radiotherapy, not on the management of brain metastases. And the reason I say that is we've got a set of we've got a set of treatment options which include things like SACT and immunotherapy. And there's a whole load of stuff around the treatment of brain metastases, including steroids, anti-epileptics, OT-PT, community palliative care and things. So all of those are important, but I want in this session really just to talk about radiotherapy because I think there's actually quite a lot to talk about. So what do we know? So the first thing is we know that prognosis differs by different patient groups. This is probably the best score that's available. This is the disease-specific GPA score. And what I want to show you here is you get a number of points, and you can get different points for different factors. But what I want to show you is even if you look in the best group, those median survivals vary a lot between non-small cell lung and breast. And if you look in the more intermediate group, similarly, those median survivals vary a lot. So, not everyone with brain mets has the same prognosis. Second thing is, certainly in breast cancer, different breast cancer subtypes probably have a different prognosis. And so you can see this is how you score for the DSGPA, and you can see that you get more points based on the subtype of breast cancer you've got, and therefore if you go back to the previous table, that's going to influence your prognosis. It is just worth saying that the DSGPA, while it's useful and it's big, it's over a long period of time, and almost everyone included in it had SRS, so it is quite a limited group of patients. And then the next thing to say is that different patients get disease in different places. So this is unpublished data from Hamoon Rosati, who's now a consultant at Barts but was my MD fellow. So he did some really nice work looking at over 400 patients with over 2,000 brain metastases from 3 different centres and just mapping where those mets occur. And so we can see that different patients have a propensity to get metastases in different bits of the brain. Okay, so we can demonstrate that there is a difference between patients, which is probably important. But the real question is, does that make any difference to treatment? So I think treatment options are surgery, whole brain, SRS, SACT, focal VMAT. There is almost no good data to choose between these. Most of these choices are made at the pre-trial stage. So you go down one route and then you report what happens. There is a bit of work comparing whole brain and SRS, and we'll talk about that in a minute. But otherwise, for example, to the best of my knowledge, there is no trial comparing surgery and SRS, for example, because those decisions tend to be made based on clinical grounds and they enroll different patients. So, historically, we have offered surgery for single or large metastases, SRS for 1 to 3 or 1 to 4 metastases, and everyone gets whole brain. There is now reasonable data to give SRS for more than 4 mets. There is reasonable data for post-op SRS, and we have some data of both posterior fossa and focal VMAT. There is still no good data on the incidence or treatment of brain metastases in the UK or really elsewhere. There are 2 studies from the UK I'm aware of, one from Nottingham and one from Imperial. In Nottingham, 50% of patients got no active treatment, in Imperial 25%. So whichever way you cut it, there's a lot of patients not getting treatment, but that proportion varies a lot. We've had access to the Parachute data set, which was whole English population, everyone having radiotherapy in England over a 3-year period. And in that 3-year period, over that 3 years, the average was 2,600 patients a year had whole brain, and they had a median survival of 4 months. We know that outcomes with SRS are much better. Median OS is about 13 months. Lesional control is about 80% at 12 months. But there's still no good UK data on SRS usage. Stephen Robinson and I and a couple of others had a paper in Clinoc a couple of months ago now, however, showing that access to SRS in terms of geographical distance and travel time varies considerably depending on where you are. So, we know that outcomes in patients having SRS are much better than those having whole brain. This is likely due to patient selection. But there are now multiple randomized trials that show that adding whole brain to SRS or surgery improves intracranial control, but not overall survival. And just to give you an example of one of these studies, this is from COCA, it's published quite a while ago now. This is a nice study. Patients can have either SRS or surgery, and then they're randomized to whole brain or not. And after surgery, about 50% get local recurrence, which is about what you see in most of the literature. And that risk of local recurrence, or risk of intracranial recurrence, is roughly halved by the addition of radiotherapy. But most of that risk of recurrence is local recurrence. And just to look at the data from COCA, this is time to PS2, which I think is a nice outcome measure. And you can see that there is absolutely no difference in time to PS2 between those who had whole brain radiotherapy and those who didn't. These are some other graphs looking at time to intracranial progression. So this is time to intracranial progression at the initial site. So if you have surgery alone, you get, I think it's just over 50% chance of local progression, which is consistent across studies. If you add whole brain to that, it comes down to about 25%. Okay. This is the risk of distant progression. This is distant progression with radiosurgery, distant progression with surgery, distant progression if you add whole brain distant to radiosurgery, distant progression if you add whole brain to surgery. So if you add whole brain, you bring the risk of distant progression down, but you don't improve survival, you don't improve time to PS2. And there are multiple other studies that broadly report similar things. So if we summarise the evidence around whole brain, focal radiotherapy and whole brain has the same overall survival as focal radiotherapy alone. Adding whole brain improves intracranial progression, but has the same time to PS2. But if you add whole brain to SRS, it makes your cognitive function worse. There is, however, an argument, and it's not a perfect argument, that when you look at the studies that compared adding whole brain to SRS, all of them were negative. But at least 3 of them went back and reanalyzed their data, and they picked out the very good prognosis patients, largely using the GPA or the DS-GPL sum variant. And in those, there is perhaps a survival of whole brain radiotherapy. And I don't think that that's inconsistent with what I've said. In most patients with metastatic cancer, they will die of their extracranial disease. Therefore, improving your intracranial control rate doesn't really improve survival. However, in the group who've got very limited or no extracranial disease, the thing that will kill you is your intracranial disease, and therefore whole brain radiotherapy may actually improve survival. The problem, of course, is that these are the patients with a good prognosis. They're going to live longer, which means they therefore are more likely to live long enough to develop neurocognitive deficits. So I think this is a difficult decision, and it's a difficult decision to make with patients. Okay. Briefly, people have compared post-operative whole brain with SRS. they have the same overall survival, but better cognition, which is, I think, not surprising. They've compared cavity SRS with observation. Cavity SRS reduces local relapse, but doesn't change overall survival. So we know after surgery, we've got about a 50% chance of local recurrence. Whole brain radiotherapy reduces that risk of local recurrence, but actually you can get most of that benefit by giving SRS to the cavity. And doing so is better for your cognition. In terms of hippocampal sparing versus standard whole brain, big American trial shows better cognitive outcomes and better functional scores as well. The only thing I'll say is, first of all, at least in this trial, it's the NRG CC001, both arms had Memantine. But the other issue is, I just want you to look at this graph, and this is why I put it up. This is time to cognitive failure. And what I'd actually suggest is what we're seeing here is that patients have about the same time to cognitive failure. It's just that fewer patients get cognitive failure. So your risk of cognitive failure goes from here to here. Okay. Still means, even in the hippocampal avoidance arm, your risk of cognitive failure is more than 50%. So hippocampal sparing whole brain radiotherapy is better than standard whole brain, but it's still not wonderful. And then a recent study, which came out earlier this year, looked at as a randomized study of SRS versus hippocampal sparing whole brain for patients with 5 to 20 METs. And this, I think, is a fairly well done study and is worth reading. They had a median of 14 METs. This is patients with quite a lot of disease. Overall survival is the same, but quality of life is better with SRS. So the problem with this is there's a lot of evidence, some of it looking all at the same thing, accrued over quite a lot of time. But I think if you put it together, hippocampal sparing whole brain is better than whole brain with respect to cognition, but SRS is better than hippocampal sparing whole brain with respect to cognition and functional scores. Whole brain doesn't improve survival or time to PS2, it's just worth saying, or steroid dose or anything else. And so really, I think that the underlying question is, how many lesions can we give SRS to? Because if we say SRS is better than whole brain, better than hippocampal sparing whole brain, and adding whole brain doesn't buy us very much, really the question is, well, we want to give SRS to everyone, but can we do that? So there's a bit of data on this. This is an old study now, but it's a nice study. Big gamma knife study in Japan. Over 1,000 patients over 3 years, so good recruitment. 1 to 10 METs, total volume less than 15 mils. It's a reasonably small volume disease. If you've got 10 METs, total volume is 15 mils. But you can see that there's no difference in survival between 2 to 4 tumours or 5 to 10. You can see, of course, is that patients with a single tumour have better survival. And I would just point out that that is a consistent finding across all studies. Okay? So people with 1 MET are biologically very odd. If we think about how brain metastases are supposed to work, it's supposed to get hematologinous spread of the tumour, they float around, they lodge in the brain. But in that case, everyone should have loads of brain mets. It does not make sense to have a single brain met. They are clearly a biologically distinctive group. And in every study, they do better. This is a systematic review of meta-analysis, again done by Hamoon, published a few years ago now. And he found 5 studies that reported the effect of the number of metastases, and that came up with a pooled hazard ratio of 1.1. So patients with more than 10 METs are at slightly higher risk of dying than those with less than 10 METs, but that doesn't mean that you can't treat them. But although that's some of the literature, and there's some other studies that haven't referenced, there's maybe a practical element here. So I think it's just worth saying that treating 4 METs is sensible and feasible. Unfortunately, we know there is very significant variation in practice. So I know that there are units in the UK that will not treat more than 3 or 4 metastases. Volume, however, is a larger constraint, NHS England suggests 20 cc, and actually I think that's a reasonably sensible cutoff. And even if you get up towards 20 cc, typically we would give hypofractionated radiotherapy. And you need to be aware that once you get up to these large numbers, your treatment times can get really quite long. And so the question I want you to think about, which we will come back to, is what is the maximum number of brain metastases we can SRS? And I'll come back to that at the end. But while the number of metastases is much harder to define in terms of what our upper limit should be, there are definitely some lesions that really are too large. And so for those patients, I think the standard approach would be to give whole brain. And what I'm going to talk about now briefly is talk about some of our experience with partial brain VMAT and posterior fossa. And one of the ways of thinking about this, I think, is what's the minimum volume of normal brain that we can treat while giving lots of treatment to the target lesions? So, some brief cases. A man in his 60s, non-small cell lung cancer treated radically in 2022, and he develops this single big lesion in the post fossa. And if you measure this is about 4.5 centimeters across that way, it's about 2.5 that way. This is about, I think, 35, 40 cc. So to be clear, this is too big for SRS. So the question here is, what do you want to treat? Anyone want to put their hand up and suggest something? Okay.
This would be someone in the good prognosis category that you mentioned earlier, Matt.
Yeah, I think he was treated 3.5 years ago. Treated 3.5 years ago, he's got no extracranial disease. However, the surgeons don't want to operate because he's got some weird platelet thing that I don't understand, because that's for the hematologists.
Anyone will do anything different? Or what you will do in your center?
So I think what I would argue here is that whole brain radiotherapy, although one can justify it if you go back to those original studies. Remember I said if you looked at the subset in the very good prognosis bit, that's whole brain in addition to SRS, not by itself. The problem here is you need to get some dose into this lesion. Okay? And so what we would do here is we would offer focal VMAT to this lesion. Okay? Sorry, let me skip that. So you outline this. This is your GTV. Got a GTV to PTV margin on of 3 millimeters. And we treat with 45 in 10 because that's our standard protocol. And the advantage of that is you give a big dose to this and you give very little dose elsewhere, and you will largely get good lesional control of this. Okay, case 2. Man in his 40s from North Wales, metastatic RCC, 18 lesions, PS1, with decline for SRS locally. Well, it's very difficult to show you the scans because I've just got snapshots, but I've tried to put up some snapshots here. So, what would people like to do for this man?
I've worked with you before, Matt. I'd like to offer this man SRS, even though he's been rejected in Wales. Don't know if anyone else has a point of view.
To be fair to Wales, he was referred to another centre and the other centre rejected it. But yeah, so to be clear, 18 lesions is not a contraindication to SRS. And if you look at these, none of these lesions are huge. This is a good example. Sorry, go on. Sorry.
Any comments? It looked like it was just background noise.
Okay, fine. So just to remind you, 18 lesions is not a contraindication to SRS, and indeed the randomised trial that came out earlier this year now shows you get better outcomes with SRS than whole brain in this group. But when we treated him, that evidence wasn't available. Okay. So this lady, woman in her 60s, metastatic high-grade ovarian, she'd had SRS in May 2021, and in January 2022, she has this MRI. So this thing is big. Okay, it's all of this and all of that. So again, this is too big for SRS. So as we did with the previous patient, we gave it VMAT, did 45 and 10. And what I've got here is an MRI from January 2022 and August 2022 here. She'd had February radiotherapy in February 2022. And what you can see is you get near complete resolution of the lesion. And as a reminder, ovarian cancer is really very radiosensitive and behaves very well. What I also want to point out, of course, is she now develops new lesions. But because you've given her focal VMAT, you can, if you want to, give these SRS. We didn't, because her extracranial disease was progressing and therefore it wasn't appropriate. But there's nothing, if she was otherwise well, there's nothing to stop you SRS. And then case 4 is a lady with metastatic breast cancer. And really, although again, this is really hard to bring out without being able to scroll through the MRI. The MRI shows a lot of disease in the posterior fossa. So you can see some of it here and some of it here. What I want to focus on is you can see the big lumps here, that's easy. And then when you look a bit more carefully, you can see the little bits. And when you look on the coronal, you can see this little bit, and in fact there's one there, there's one there. There's this thing, there's probably one there. So in fact, this isn't SRSable. Because if you try and give a decent dose, these lesions are so close together, you're going to get bridging. So she's only got one lesion outside the post fossa. And that goes back to the fact that different patients develop different patterns of disease. And you need to look at where their disease is and not treat everybody the same. So we gave post fossa radiotherapy. We give 25 gray in 2 weeks because that's basically what we do for our whole brains. And one of the reasons we do this is then if you treat it, if you got residual lesions, you can definitely boost those because we know that giving whole brain and then an SRS boost is safe. And so what I put up here is the red line is PTV, and I set the isodose colour wash here to 15 gray. So you get, fairly conformal doses. This treatment's pretty well tolerated. Okay, so I've shown you 4 cases. 1 where lots of lesions is not a contraindication to SRS. 2 where big lumps you can treat with VMAT. And 1 with lots of little things, but all in one anatomically defined compartment where you can treat the compartment. So, what do I think we should do? And I fully accept this as a personal view. So, we should still stick with surgery for single lesions, good prognosis, that's good. I think we should give SRS for multiple small to intermediate lesions, and you just have to be willing to treat many lesions, and if you think that your tech is not up to it, then you should refer elsewhere. And then I think we offer partial brain radiotherapy for larger lesions. You could do that with VMAT for focal large lesions, or treat the post fossa. And I then think we should be treating cavities with a focal radiotherapy technique. I've deliberately chosen that form of words, as some of you will know. NHS England declined to commission cavity SRS. Informally, we know that many units in the country are using a variety of focal radiotherapy techniques to treat cavities. Whether that's SRS or whether that's VMAT, and what the difference between SRS to a cavity and non-coplanar VMAT is, slightly escapes me because they seem rather similar. But nonetheless, lots of people are treating cavities. And I think that really whole brain radiotherapy should be referred for patients with poor prognosis or things like leptomeningeal disease that you clearly can't treat with this, or with very careful counselling, those with a very good prognosis where their main risk of dying is from intracranial disease, and then we should perhaps be giving them whole brain radiotherapy, probably hippocampal sparing whole brain radiotherapy, but you have to caution them about the risk of cognitive impairment, because although whole brain is better, hippocampal sparing whole brain is better than whole brain. If you remember that graph I showed, over 50% of people developing who had hippocampal sparing whole brain and the MAT still developed their trial-defined cognitive failure. So although it is better than whole brain, hippocampal sparing whole brain is still not toxic. And just to be clear, stereotactic radiotherapy is much more hippocampal sparing than hippocampal sparing whole brain. So I also want to, actually we'll just pause there. Any questions about anything I've said so far?
So we have a question from Samira. She's asking,
Oh, yep.
Treating 18 lesions with SRS will increase the planning or treatment time. What's for you?
Yes, yes, it will. It's quite platform dependent. So, for example, we're quite lucky. We have access to both Linac and Gamma Knife, but at the moment, Gamma Knife we use, the sources are quite old. So I treated someone with 20-something lesions about 4 weeks ago, but the treatment time was 8 hours, which is really not ideal. On the other hand, if you had new sources, the treatment time would be about 4.5 hours. So that would be a bit more acceptable. With other techniques, things like HyperArc, you can probably deliver multi-mets treatment in no more than about 20 minutes. So it may increase the planning time, it may increase the delivery time. One of the things we might do is, even if you're treating everything with a single fraction, we're clear when we see patients in clinic that we tell them it will be between 1 and 3 fractions. And that's because even if you treat everything in a single fraction, if you're treating a lot of lesions, you might treat lesions 1 to 10 on Monday and treat lesions 11 to 15 on another day. Even though each of them is being treated with a single fraction, you just split it like that to make it a bit more palatable for the patients.
Thank you. Any other questions?
Any other questions?
Question from my side. What's your approach if you have like localized leptomeningeal disease?
So you need to be really careful about what people say when they say leptomeningeal, because it gets bandied around. So I want to differentiate between 3 main patterns. The first one to distinguish between is not leptomeningeal, but pachymeningeal disease. This is not this very fine spread stuff that you typically see best in the cerebellum. It's often thick dural lesions. Patients with pachymeningeal disease clearly have a much better prognosis, and we've treated many of those with focal high-dose radiotherapy, and they do quite well. The next thing is when you have isolated lesions where around the base of the lesion you get the feeling that there's a little bit of leptomeningeal spread, but just around 1 or 2 lesions. And those, I would just treat the lesions and I'd include that little bit of leptomeninges. And then, of course, the third group are those with florid, widespread leptomeningeal disease, where they typically have worse disease in the cerebellum, or at least it's easiest to see in the cerebellum. They characteristically present with multiple non-contiguous progressive cranial nerve palsies. So the clinical story is they go deaf in their left ear, they get numbness in their right forehead, numbness in their left chin. There is no anatomical location that gives you all of those deficits, okay? And that is the thing that should alert you to leptomeningeal. Leptomeningeal disease can be very difficult to diagnose. We've seen it, and I've seen it, diagnosed and missed, sort of, and come via all manner of routes. I've had patients referred via ENT because they presented with hearing problems and got referred to ENT, and that they've come that way. It's really about taking a history. For patients with florid leptomeningeal disease, then the treatment is either whole brain or craniospinal, depending on, or intrathecal chemo, or however you want to manage leptomeningeal disease. But you just need to distinguish leptomeningeal from that little bit of focal leptomeningeal spread just around the lesion from pachymeningeal, which is something entirely separate.
Thank you.
Okay. Right. I'm going to talk a little bit more about whole brain radiotherapy because when I was a registrar, which I accept was a long time ago, I'd been a registrar for about 9 months. My first couple of registrars were at Mount Vernon. We used to do a clinic on a Friday, and there was a bit of a lull in the clinic. It was a nice clinic because there were multiple consultants around. And so I liked, I'd been a reg for a bit, I'd done a fair amount of whole brain. And so I said, so what? Whole brain doesn't seem to work terribly well because everyone seems to die. But, what are the benefits of it? And various consultants sort of said, oh, well, it improves steroid use and it improves performance status. And then I said, oh, I see, that's good. Do you have any references for that? And everyone looked very sheepish. And I want to show you some of the literature. So this is one retrospective paper. There are lots of them. This was published in EJC in 2002. 75 patients, whole brain radiotherapy 20 and 5. Median survival is 2.5 months. At 1 month, 20% of patients had improved symptoms and 4 patients had improved PS. What I want to point out is almost everyone gets an improvement with steroids, but there's no relationship between the edema you see on the scan and response to steroids, and there is no relationship to steroid response and radiotherapy response. And this was published a long time ago. And then, of course, the UK did really a very good trial. This is the Quartz trial. So I hope most of you are aware of this. There's a non-inferiority phase 3 RCT, patients with non-small cell lung cancer and brain mets. And the primary outcome was QALYs, calculated by combining survival and EQ5D scores. And so it was randomized to best supportive care and steroids versus best supportive care steroids and radiotherapy 20 and 5. And this is a big trial. 538 patients from 72 centres. The median survival is 9 weeks, which is pretty much 2.5 months. 84% had a response to steroids, very similar to the 85%. No change in steroid use with radiotherapy, and QALYs were a tiny bit worse if you avoided radiotherapy. This is survival, and this is average quality of life. So I remember when this came out, it's a major practice-changing trial, published in 2016. So my question is, does anyone know when the first trial that showed this was published? Just take it, someone guess a year.
You can write in the chat as well, if you would like.
Sorry?
You can write in the chat as well, if you would like.
Yeah, or you can write in the chat. Just guess a year. And the first trial that showed the failure of radiotherapy to improve outcome in non-small cell lung cancer with brain mets. Okay. So I found, after a bit of digging, I found this study, and it's a really good trial. So it's by John Horton. It was published in the American Journal of Radiology in 1971. And if you look, it's very similar to Quartz. They were using prednisolone and radiotherapy. They gave 4,000 rads, because at the time that's how we calculated. They gave 40 gray over 4 weeks. They were using bulk, since the late 60s. And they assessed performance status and median OS as the outcome. Very similar to Quartz. And I have reproduced their comment here. Results indicate that a combination of irradiation and prednisone offers only a slight advantage over prednisone alone. this hardly justifies the expense, work and inconvenience to the patient and his family of a 4-week course of irradiation, taking up about a third of his final days. So, I want to remind you that this was published in 1971. I was a registrar at Mount Vernon in about 2009, 2010, and Quartz was published in 2016. As a profession, we did not cover ourselves in glory with this, because we spent the best part of 45 years giving treatment that we knew was ineffective to a bunch of patients who had an extremely poor prognosis. So, that's what we have done and what we can do at the moment. Things just to think about, we might be able to do in the future. Lots of interest in neoadjuvant SRS pre-op. It's probably of some value. One of the problems with surgical resection of brain mets, they probably carry up to a 20% risk of leptomeningeal disease. Neoadjuvant SRS seems to resolve that. The other issue is, if you believe you're going to treat the cavity anyway, the advantage of the neoadjuvant SRS is it's much easier to do the target outlining, on an intact lesion than it is to do the cavity. We might look at doing dose-escalated VMAT, and I'll talk about that in a minute. You might look at doing SRS to big lesions only. So maybe if a patient's got 50 lesions, but many of them are tiny, we know that tiny lesions don't cause patients any problems, maybe we should just treat the big ones. And then there's some interest in a bit of work on staged SRS. So that's where you treat a lesion, typically with between 7 and 10 gray. You wait 2 to 3 weeks. You treat it again with 7 to 10 gray, wait 2 to 3 weeks, and treat it again. So you're still giving a dose of around 27 in 3 or 30 in 10, but split over multiple weeks. Now this goes, of course, against all radiobiology, but the advantage is that the lesion will often shrink over time, and therefore the toxicity of your final fraction is much lower because the lesion has shrunk. I think there are lots of questions about, can we predict who will get METs or where those METs will be? So every trial of PCI outside of small cell lung cancer has failed, but maybe it's failed because we can't predict who's going to get METs well enough, and maybe we don't need to do whole cranial PCI. If you go back to those pretty pictures I put up at the beginning, we know that some cancers are much more likely to go to certain bits of the brain, so maybe you could do PCI but only of a lobe. And just to say that the RCR brain mets audit is just closing. If your centre hasn't contributed, please do. It is, as far as I know, the first attempt in the UK to understand the scope of brain mets practice nationally. And then just to say the practice develops, this is just some local practice from Charing Cross. So the important things here are number of patients in blue. So the number of patients has gone up, but what's really changed is the number of lesions we treat. Okay, and this has real complexity issues because this is a lot more work than this. Okay, so the workload has changed even if the number of patients hasn't changed as much. And of course, technology develops. So variant HyperArc will now treat multiple METs in about 30 minutes. And this, for those of you who haven't seen it, is ZapX. So this is developed by the same person who developed CyberKnife. This is a self-shielding gyroscopic LINAC. And because it's self-shielding, it doesn't need to be in a bunker. And so you can see here, there is a glass wall because this treatment room directly looks onto the outside world. Famously, there is ZapX in a Japanese train station, so you can get your brain mets treated on the way to work if you want to. So ZapX is really nice. There is not yet a ZapX in the UK. I think it'd be great to get one. You could put one in your garden if you wanted to, because you don't need a bunker. But obviously, it's slightly difficult to persuade people to buy. And then just those of you who work with me will know about this. We published a planning study a few years ago, but it's in the Green Journal, it's open access if you want it, showing that you can dose escalate large lesions and you give much less dose to the normal brain and much more dose to the lesions. This trial, which is called Beat Breast, is just about to open. The companion trial called Aroma, which is basically the same as Beat Breast, but unlike breast cancer, is all histologies, will open, I hope, before the end of the year. So, in summary, brain metastases remain common and devastating. We can't yet predict who'll get them or where we'll get them. Where possible, give focal therapy, bearing in mind that stereotactic is probably more possible than you think, and there are other focal radiotherapy approaches that still give much more dose to the tumour and less dose to the brain than whole brain. Stereotactic radiotherapy is excellent palliative radiotherapy, and we should use it in those who might benefit. And if not, can you give focal radiotherapy or post-fossa or something else that doesn't involve irradiating the whole brain? And just to say thanks to people at the Computational Oncology Lab at Imperial, particularly Hamu, who's contributed quite a lot of this work, and the neuro-oncology team at Imperial more generally. And those are my contact details if anyone wants to get in touch afterwards. Thank you very much.
Thank you, Dr. Williams. That's very comprehensive and useful. Thank you so much. Do we have any questions? Please make use of that opportunity. We have Dr. Williams, he is one of the experts. So please make the opportunity to ask questions if you want to clarify or to contribute. Yeah, go on, Mohsen.
Thank you, Dr. Williams, for your talk. We don't have SRS in our center usually, but may I ask you what is, in your clinical practice, a cutoff in patient who should we offer high-dose palliative VMAT radiotherapy? Like, what is in your head, like number of lesions you would like to treat, and what sort of tumors that are likely to respond?
Yeah.
What do you suggest?
So we give 45 in 10 normally, although in fact we've got a patient on treatment at the moment who's got 3 large metastases, and we've gone with 35 in 10 to reduce the spill. So I think I would use focal VMAT in people who've got a large number of small lesions. Sorry, no, wrong way around, sorry. A small number of large lesions, okay? So people who can't have SRS because their lesions are too large, they've got 1, 2, maybe 3 lesions, then I think focal high-dose VMAT works quite well. You get much more dose to the normal, to the structure, much less dose to normal brain. But at the other extreme, if someone has 10, 12, 15, 20, 25, 30 small metastases and has good performance status, they really should be offered SRS. Okay? And I think we just have to accept that those patients should be referred elsewhere.
Can you combine VMAT and SRS, Dr. Williams?
Yeah, we tend not to do them at the same time. But for example, we've definitely treated people with maybe 1 large lesion, which we VMAT, and then 6 weeks later, if they've got a couple of small things, we'll bring them back and SRS the others.
And also the question, could you give whole brain radiotherapy after SRS?
Yeah, I mean, there are loads of trials that look at combining whole brain and SRS, lots of trials. So there's loads of safety data, so that's not really the problem. I think that, practically, if we see a patient and we think their extracranial disease is reasonably well controlled, so for example, the question I ask my colleagues is, if I control their intracranial disease, how long will they live for from their extracranial disease? That's slightly different to saying, what is the prognosis? Because what is the prognosis combines a notion of intracranial disease. So my question is, if I control the brain, how long are they going to live for? If the answer is more than 6 months or 6 months or more, and they are pretty much PS 0 to 2, then where possible we will offer focal radiotherapy, ideally SRS as long as the lesions aren't too large. You can give SRS. When you follow, one of the things is once you give SRS, you have to accept that you're going to follow people up. So if, for example, you have a patient who will not come for follow-up, I'm not sure you can really give SRS. Because the point about SRS is you are committing to treating lesions and sparing normal brain. And then, at follow-up, if they get new lesions, you can just give more SRS. Practically, we'll do that. We'll give SRS. If people get new lesions, we'll give another round of SRS. If straight after their second round, so we scan at 10 weeks post-SRS, if straight after their second round of SRS, they've got more new lesions, that is the point at which I would suggest you should then switch to whole brain. Okay, and there's no evidence for that. It's just pragmatic.
That's fine. That's very useful. And yeah, go ahead, Roger.
I was just regarding the focal VMAT. Do you see much radionecrosis, or the dose not high enough compared to like an SRS?
Yeah, you do, but you also have to accept patients have to live long enough. So these are patients who, even with focal techniques, tend to have a fairly poor prognosis. So we're still in the middle of finalising our VMAT write-up. The real problem with the VMAT group is the median survival is pretty poor, but when you look at it, it's because basically they separate into two groups. And there's a group who just deteriorate really quickly and die. And then there's this group who live ages. We've had some people who live a long time. And it's definitely true that if they live a long time, there's definitely a risk of radionecrosis. But, that's why that's part of the consent process. But it's still better than giving a whole brain.
Sarah?
Hi, sorry, this might be a stupid question. I've been away from clinical practice for quite a while. But it's just a very sort of practical question. So for the focal VMAT and the posterior radiotherapy, are you doing that for your colleagues, as in if it's a breast patient, the breast team would refer to you to plan that?
That's really interesting. So there's a national brain tumour kind of case discussion forum. It's deliberately not called an MDT, but it's sort of a national MDT, except it's only oncologists. And in fact, that question came up at the last thing. So it turns out there are quite a lot of people in the UK doing some form of focal VMAT and some form of post-phospho-radiotherapy across different centres in different contexts and everything else. And we talked about this. So at Imperial, we do it. But one of my colleagues at Guy's says their team, the disease-specific team, does it, but they get one of the neuron team to have a look at it.
Okay, thanks. So it just depends on the local setup.
I think it just depends on how you want to arrange your local services. And I will say that posterior fossa volumes are not difficult to do. The VMAT volumes are really not difficult to do. You draw around the white bit and put a 3mm margin on it. That's it. So I don't think there's any technical reason why you can't. I think it's more a governance thing, but I would have no problem if the rest of our department wanted to do that. Do you see what I mean? I think that would be perfectly sensible. Mm-hmm. Historically, we've done it, but I'm always happy to give up bits of my practice to my colleagues.
Thank you.
Sorry. Any other questions? So another question from my side, Dr. Williams. Would you consider re-irradiation with SRS?
Yes.
Yeah.
So there's really quite a lot of data now on re-irradiation in SRS. So typically, I've just rewritten our SRS protocol. I am trying to encourage my colleagues to standardise on 21 gray and 3 fractions for re-irradiation, mainly because the literature is dreadful and bounces around all over the place. And I actually felt it might be useful if we just agreed we're all going to do one thing, because at least then physics know what we should be doing and what we should be planning to. But there's really quite a lot of data. The real problem is differentiating between radionecrosis and progressive disease. And that remains a bit of a nightmare, to be honest. You can do perfusion MR, you can do trams, all of which helps, none of which is perfect. And for very obvious reasons, if you've got radionecrosis, you don't really want to give them another round of radiotherapy. And just to be clear, you can get mixed recurrence radionecrosis. We've definitely seen that. I've had the surgeons go in and excise things, and the pathologists go, no, it's all dead, there's definitely no tissue. And then the follow-up MRI 3 months later clearly shows progression in the surgical cavity. So there must have been some residual viable tumour in there some. So it's differentiating between radionecrosis and progressive disease is really hard.
Thank you. Another question from Mohsen. Yeah.
Sorry, Dr. Vidya, just a quick question regarding to my first question. What is the volume cutoff if you are giving high-dose palliative radiotherapy? What is the sort of volume you would look that this is the ballpark figure? If it goes beyond that, I shouldn't be offering high-dose VMAT. Have you got any figures in your head or approximations?
No, I just sort of eyeball it. The other problem is, I showed you, okay, I'm just going to put these up again because it's kind of worth talking about. Let me just, hang on, give me a sec. So, although we're doing this as a trial, we've actually treated our first patient with the technique, but off trial because the trial's not yet open. Just give me a sec. Yeah. So, the way that the beat breast aroma technique works is need to think about what drives toxicity. And what drives toxicity, remember this is metastases. Metastases push normal brain out of the way. So what drives toxicity is the volume of normal brain that you irradiate to a certain dose. So what we've done in aroma and beat breast is we constrain the marginal dose to 25 in 5 for small lesions and 24 in 5 for large lesions. And then we internally dose escalate so that the centre gets very hot. And the reason that we think that is sensible is it's this bit of the brain dose that drives toxicity, not the dose in the middle, but it's the dose in the middle that partially drives response. So I apologise for that because I fully accept I haven't answered your question. Tell you what, we've got a minute. If anyone else wants to ask another question, I will do my best to answer that question. I just need to look at something. Any other questions?
So meanwhile, if you could just fill in the feedback form, please, to find the answer.
Okay, of the patients we have treated, the median volume, this is a very quick check, is about 25 gray.
Or did you mean
This is the
25
medium
mils?
dose.
Sorry, 25 cc. Sorry. With the upper quartile being 27. I will say, I think we are sort of, we've gone bigger than that. We've got a patient on treatment at the moment whose volumes are bigger than that. And interesting, so she's got 3 quite big lesions, and we've dropped the dose to 35 in 10. And she came to clinic today. She's entirely well with no side effects and PS0. So, you know, you can get away with doing it.
Thank you.
It's fine. Any further questions before we close? That's fine. In this case, thank you so much, Dr. Williams, for your contribution. Really appreciate it. This was really useful and very pragmatic talk. Thank you so much for your time.
You're very welcome. So if people have got questions about brain mets, I'm always happy for people to email. And just for those with an interest, the British Radiosurgery Society, our next conference is in January next year, and there'll be lots of stuff on brain mets there. Anyway, I hope it was useful. Please feel free to drop me a line if you've got any questions.
Thank you.